again, and we always welcome your phone calls during this hour. Indications.
Right. Well, this is more of a slide regarding just Valium-type medications like the benzodiazepine that we use, Trazolam. It's preoperative sedation, like before they come in and the night before. They can get a good rest if they're, some patients don't need to be sedated. They just want to be comfortable when they come in. So we may prescribe just Valium that night and give them Valium in the morning, and then it's not truly sedation dentistry, but they're definitely more sedate than they would be otherwise.
They're not on edge.
Right, exactly.
They're comfortable coming in. It's like taking a flight if you're a little bit nervous.
Precisely.
Okay, next slide. Cautions.
Smokers there's an enzyme that's affected by nicotine. So for a person that smokes, they end up using more drugs, so it takes a little more to get them sedated. They also have issues with breathing a lot of times. Probably the biggest thing on this slide that I want everybody to understand is the anterior grade amnesia, and that's the not knowing what happened after the procedure, which is really,
that what that means?
Yeah, the anterior grade amnesia means that from the initiation of the pill, they don't remember anything after that. So it's nice to forget that you had injections, because we still use local anesthetic during this procedure. You're still getting local injections, but you don't remember that you got the local injections. You don't remember that we took out a tooth. You don't remember anything that went on. You remember getting to the office, and that's usually all you remember.
So when you say local injections, you mean the Novocaine?
Right.
Oh, is that right? So just because you are asleep, that doesn't mean that you are also...
You still feel pain.
You still will feel the pain.
Well, so you can. We find that you need less anesthetic when you're sedated than when you're not. So,
interesting.
And less post-operative pain as well. That's also a unique part of sedation dentistry. The patients usually don't have as much post-operative issues where they, need more drugs for pain management.
For the viewer out there that's hearing, okay, you're going to be given a pill and you are not going to remember, can you ease their minds that they're not going to make a fool of themselves by saying something stupid? Because we've always heard of that concern that, gee, what did I say, or did I embarrass myself?
Sure. We have a private operatory that we do sedation dentistry in, and it's very, private for that reason, because I want patients to feel comfortable knowing that they're not on display.
Right.
It's a big deal, and we don't sedate children, so it's an adult procedure for adults that need dentistry done in this fashion, and they don't need to be on display. So it's private. Patients don't typically say a lot of stuff, but they do remember what we say. So that's important for us not to say things like, let's go here for lunch today.
Right. Exactly.
It's important to understand that there's a patient there that you're working on, and you don't want to talk about odd things.
Let me ask you something. If they are asleep and they have not been given enough Novocaine, can they let you know, hey, look, doc, I feel this, or are they just in a comatose state that they can't communicate with you?
No, they do.
They do. How do they do that?
Well, they let me know.
By raising their hand?
Right. Or they'll make, like any one of us, when we feel pain, we'll say, hey, that hurts. Or
is that right?
Or they'll
And would they even remember saying that?
Probably not, but, we're in tune to watching their reaction. And if they're making an odd facial, like they're grimacing in pain, that's obviously they're not numb.
That's part of the monitor.
Right. Well, you got to be paying attention to the patient, yeah.
Interesting.
So we don't ever want them so sedate that they can't respond. That's not the objective. So the main objective is for them to be comfortable throughout the procedure and not remember having dentistry done.
Okay, let's head up to Huntersville. We have Tom with us now. Hi, Tom. Welcome to the show.
Thank you.
What's your question for Dr. Ed Porter?
I'm in a high-risk situation. I've had 5 heart attacks.
Okay.
And need to have all of my upper teeth extracted.
Okay.
And it's been recommended that I use a surgeon and do the procedure in a hospital. Is this necessary?
All right. He kind of alluded to the higher risk patients here. Let's hear what he has to say. Can you respond to that, Dr. Porter?
Thanks for calling, Tom. I think without a doubt that you are probably somebody who's better served in a hospital setting. With 5 heart attacks as a history, that's a pretty strong medical history towards a complication. So you may not be the best candidate for a procedure that's done in an outpatient setting like the way we operate.
You have a follow-up, Tom?
No, that satisfies my need. Thank you.
All right. I was going to ask you, if you're still with us, though, why would you be, are you apprehensive about going to a hospital to have a dental procedure as opposed to an office?
Well, I'm uninsured because of my medical history.
Mm-hmm.
And I've gathered finances to pay for the surgeon, but now the hospital is an added expense. And so therefore my question, do I have to do the procedure in the hospital?
Right, and he has a follow-up here.
Tom, I think there's a lot of very qualified oral surgeons out there that could see you in an outpatient setting, and that's probably the better option for you, where you're IV sedated and not sedated via a pill like we use. So I think for you, definitely an oral surgeon is the proper route, and not necessarily in a hospital, but definitely with an oral surgeon in an outpatient setting with an oral surgeon.
Well, great. I'm glad I asked that follow-up because outpatient would be an option for you. What were you going to say, Tom? Okay. Thank you so much for calling in. Let's head over to Albemarle now. We have Betty with us. Betty, welcome to Healthwise. You can go ahead and turn down your television, Betty, and just talk to me in your phone here. Thank you so much for calling in. Let's head over. I don't think she's going to. Betty, you with me? There's that 7-second delay. Okay.
Okay.
I think we cut her up and she was ready to talk to us. Is she gone? Betty, you there?
I'm there.
Okay, you go ahead. What's your question?
I'm wondering whether this is appropriate for someone 85 years old.
All right, so she's concerned about age. And you know, Betty, we have this question that pops up just about every week here on Healthwise. I'm interested to see what Dr. Ed Porter has to say.
And I'm in very good health.
I'm glad you mentioned that. Very good, because that was going to be our follow-up question. You're in excellent health, 85 years old. Hey, Betty, you got a lot of life to live. Let's hear what Dr. Porter has to say.
That was going to be my first question was, how's your health? And at 85, we treat a lot of patients in that age range today. I think everybody is living longer, and if you're healthy at 85, there shouldn't be an issue. There shouldn't be any issue at all, Betty, with getting this type of sedation, no different than anyone else we'd sedate.
Betty, I hope that helps. And if you need some dental care and you're apprehensive, perhaps this show is helping explore the option for you. Let's go back to the slides if we can. The next slide. And is it cautions?
Contraindications.
Yes, here we go.
Yeah, like we said earlier, smokers are a little more difficult to manage, and definitely somebody who has emphysema is not a person that I would sedate. Psychosis, if they have any history of any kind of psychiatric disorders, they're not going to qualify for this. Acute narrow angle glaucoma is interesting because the drug increases ocular pressure, so we don't want to sedate anybody with that.
What would that do, pressure in the eye?
Well, you don't want to damage their eyes for life, so this drug will increase ocular pressure, so we definitely don't treat those patients. Known hypersensitivity, obviously, to these types of medications, and then pregnancy is a big deal because there's a baby on board, so
right.
It's also transferred in human milk, so even a lactating mother we would not sedate.
I can see emphysema, but why you earlier said breathing issues? Would that include asthma?
Well, a well-controlled asthma patient is fine, but I think one of the it was the biggest risk factor for this drug is respiratory depression. So a person that has smoked for 40 or 50 years that has a lot of congestion and breathing issues is not.
How about someone with sleep apnea? Can you put them on the CPAP while they're being worked on?
No.
No.
Because it's in their mouth. It's over their face too. What we do is monitor those patients, and if we keep them, sedated to a level where we can treat them successfully and carefully, they work just fine. Because we're monitoring that pulse ox, the pulse oxidation again, or the oxidation in the bloodstream. Which
Interesting.
Is the most important thing.
Let's go to the next slide if we can. Number 10, reversal agents. What does this mean?
Well, whenever you do anything like this in medicine or dentistry, you want to be able to reverse it, and flumazenil is the drug of choice here. We inject this under the tongue, and this is a total reversal of all the effects that the triazolam has. It binds to that GABA receptor that the triazolam is trying to bind.